All right, let's get right into it. Today, you're not just a viewer, you're the doctor. We're going to step into the clinic and solve two really tough medical cases. You'll get all the clues, but the life or death decisions, well, those are all on you.
So here's the deal. We've got two patients, and the stakes could not be higher. You're going to see everything I see, the symptoms, the lab results, the scans. Your job is to connect those dots and make the right call. You think you're ready? Let's find out.
Okay, time to dive in. Go ahead and scrub in, grab your chart, because your first patient is waiting.
So our first case is a young guy, an athlete, who seems perfectly healthy on the outside. But something's not right, and it's our job to figure out exactly what's going on. Okay, so meet patient number 1. He's 35 years old, should be in the absolute prime of his life, but instead, he's getting short of breath, that's what we call dyspnea, and he's feeling chest discomfort anytime he really pushes himself physically. For an athlete, this is a huge red flag.
Now, this is where the detective work really begins. First off, his vitals, his pulse and blood pressure, they look totally fine, rock solid. But when you listen to his heart with a stethoscope, you hear a really harsh murmur. And here is the absolute kicker. That murmur gets louder when he does something called the Valsalva maneuver. You know, like when you bear down to lift something heavy? That's the maneuver. And a murmur changing like that is a classic clue that should really point us in the right direction.
And boom, the lab results bring everything into sharp focus. The ECG shows his left ventricle is hypertrophied, meaning the muscle of the heart's main pumping chamber has gotten way too thick. Then an ultrasound of his heart confirms it. The wall between the chambers is just abnormally large. It's like a doorway that's slowly getting narrower and narrower, and it's starting to block the blood from getting out. That's our obstruction. Oh, and one piece of good news, his troponin levels are normal. That tells us he's not having a heart attack right this second.
Okay, so you have all the pieces of the puzzle. A young athlete, a very specific heart murmur, and images showing a thickened heart muscle that's causing a blockage. So what's your call? What's the very first thing we should do for him? All right, let's break this down and solve the puzzle. It's pretty clear at this point that the diagnosis is Hypertrophic Cardiomyopathy, or HCM. So, what is HCM? Well, it's a genetic condition where the heart muscle just gets thicker and thicker, but not because of something obvious like high blood pressure. Think of it like a bodybuilder's muscle that's just gotten too big for the room it's in. And that overgrowth can get so bad that it literally blocks blood from leaving the heart. It creates a bottleneck, which is exactly why our guy gets so out of breath when he tries to exercise.
Okay, so here are our choices. Let's think through them. Aspirin? No, we're not worried about clots right now. Amiodarone? That's for weird heart rhythms, and that's not his main problem. What about something more drastic, like surgery, to actually shave down that extra muscle? Whoa, hold on. That's a huge operation, and it's reserved for really severe cases that don't get better with medication first. We are definitely not there yet. So surgery and ablation are off the table for now.
And that leads us to the right answer. The correct first step is A, start him on oral beta blockers. This is the absolute standard, first-line treatment for HCM. These meds slow the heart down, which gives the chambers more time to fill up with blood between beats. It also helps relax that overgrown muscle, which reduces the blockage. It is hands down the safest and most effective thing we can do for him right now. And just like that, you made the right call. Case 1 solved.
All right, one down. Let's move on to our second case. This patient is a totally different ballgame, with a much more complex history we need to unravel.
So patient number 2 is a 45-year-old man who just feels awful. He's got a fever, a general feeling of malaise, and he's been losing weight. But listen up, because the most critical piece of information on this entire slide is his history of intravenous drug use. That one fact should immediately set off alarm bells and point your thinking in a very specific direction.
And as we dig in, things get more concerning. He's been feeling sick for about 2 weeks, also with shortness of breath. But here's the big one. He has a new heart murmur. Anytime you hear a new murmur, that is an alarming sign. And then we see this physical clue, Janoy lesions on his palms. These little painless red spots are a classic, almost textbook sign that bacteria from an infection in his blood have traveled and set up camp in other parts of his body.
And now the labs tell us the whole story. 3 separate blood cultures all came back positive for the same culprit, Staphylococcus aureus, which is a really nasty, aggressive bacteria. An echo of his heart confirms our worst fears. There's a vegetation, which is really just a clump of bacteria growing right on his tricuspid valve. Add in those sky-high inflammatory markers, and there is zero doubt he has a major infection raging inside his heart.
So the picture couldn't be clearer. A dangerous bacterial infection has taken hold on one of his heart valves. So what do? What is the single most important, most urgent first step we need to take?
We're cracking a case of what's called infective endocarditis. We've got the diagnosis, now we just need the right plan of attack.
So infective endocarditis, or IE, is an infection of the inner lining of the heart, almost always on a valve. And this is a textbook case. See, when bacteria get into a vein, the very first place that blood travels is to the right side of the heart. That's why in patients with a history of IV drug use, the infection so often lands right on that tricuspid valve. And the number one bad guy in these cases? You guessed it, Staphylococcus aureus.
So what's our move? Oral amoxicillin? That's like bringing a water pistol to a 5-alarm fire. Not gonna happen. Urgent surgery? Maybe later, but only if the valve gets destroyed or he goes into heart failure, and he's not there yet. Blood thinners? No way, that's way too risky. And just watching and waiting? With an active infection growing on his heart valve? That would be a fatal mistake. The name of the game here is speed and power. The only correct answer is A. Start IV vancomycin immediately. This is a big gun antibiotic that's powerful enough to take on the most dangerous strains of staph, including MRSA. With an infection this serious, you absolutely do not wait. You hit it hard and you hit it fast. And with that, puzzle number 2 is solved.
Okay, we solved both cases. Now let's just take a step back and zoom out. What's the blueprint here? What can these two very different puzzles teach us about the art of medical diagnosis itself?
When you look back, 2 really important principles jump out. First, you have the principle of escalation. For our athlete, we started with the safest, easiest option first, the medication. You never jump straight to the big invasive stuff like surgery unless you have to. You always start with first-line therapy. And second, there's the power of context. With our second patient, his personal history wasn't just some background noise, it was the single most important clue that unlocked the entire case. It pointed us right to the bug and right to the cure.
You know, it reminds me of this quote from Voltaire, who kind of cynically said that a doctor's job is to amuse the patient while nature cures the disease. And while, yeah, that's a bit harsh, there's a grain of truth in it. Our job wasn't to magically fix these patients. It was to make one single correct decision. The beta blockers to help the heart work better, the antibiotics to clear the infection, that then allows the body to do its own healing. It's all about picking the right tool at exactly the right time.
In the end, what these cases really show us is that diagnosis is a form of storytelling. It's about taking all these scattered clues, a weird sound, a fever, a lab result, and weaving them together into a story that makes sense, one that explains what's wrong and points the way forward. Every patient who walks through the door brings a new puzzle, a whole new story just waiting to be told. The only question left is, are you ready to solve the next one?